Good morning. Today I'm going to discuss with you critical concepts in management of hypertension. So this is a special workshop within the series of continuous medical education. So I reviewed more than 125 articles that are recently published, and I'm going to focus on these articles under these corners. I'll start with the introduction and special issues regarding how to monitor blood pressure. Then, if there are any guidelines in 2017, so I'm going to address Canadian guidelines for management of hypertension in adults that was released just 1 month. Nephrology perspectives of hypertension, so I'm going to tackle hypertension and chronic kidney disease, renal vascular hypertension, and other renal aspects. Management of hypertension in diabetes with pregnancy. I'm going to just focus on some antihypertensive drugs, especially diuretics, beta blockers, and the interactions between other drugs. And the last topic before conclusion will discuss hot issues and resistant hypertension, and then I close my presentation. Before I'm going to discuss the hypertension, we should be aware how to risk stratify the patients. So one of the important risk stratification is to know heart risk. And we are fortunate today because we have a lot of technology. So if we write on Google heart risk calculator, and then you will find this page. Just specify the age, the gender, race, write the total cholesterol in milligram per deciliter, high density lipoprotein cholesterol, and then you get the blood pressure, systolic blood pressure, diastolic blood pressure, the patient is treated or not for hypertension, then diabetic or not, and smoker or not. Just click and you'll find, if we put these variables like this, you will find the risk for this patient is 42% 10-year risk of heart disease or stroke. And you will find within the calculator advices toward using of aspirin, high intensity statin for this patient, and the lines of treatment including thiazide, diuretics, ACE or ARBs, or calcium channel blockers. So all these are good facilities to stratify the patient to start with. One of important point is how to measure blood pressure, because it is a very amazing and very difficult to stabilize the environment within a research during the real clinical practice. So the advice is there are important elements for correct blood pressure measurement and technique. First, the patient should sit in a chair with his or her back supported and should rest for at least 5 minutes before the blood pressure is measured. Second, the patient's arm should be at the level of the heart. Third, the length of the blood pressure cuff's bladder should encircle at least 80% of the arm's circumference. Fourth, the clinician should inflate the cuffs to pressure 20 to 30 millimeter mercury above systolic pressure, as first identified by palpation of the distal pulse. The pulse disappears when cuff pressure exceeds systolic pressure. Fifth, the pressure in the cuffs should be released at a rate of 2 millimeter mercury per second. Sixth, the clinician should obtain at least 2 readings separated by at least 30 seconds, 1 or 2 minutes even, and average them. If these differ by more than 5 millimeter mercury, additional readings are necessary. The readings should be rounded off to the nearest 2 millimeter mercury. In some clinical scenarios, additional measurements are necessary, including those of the legs or opposite arm, or measurement taken with patient in different position. This article addresses the automated devices, and it seems that automated devices are very important, especially if we select the recommended automated device as I'll mention within the guidelines. Again and again, regarding the cuff, we should respect the cuff size, because this slide shows 3 sizes. So we have regular cuff bladder size, 12 by 23 centimeter, large cuffs between 15 and 15 by 33 centimeter, thigh cuffs 18 by 36 centimeter. If you use the regular cuff for arm circumference between 28 centimeter or less, it will be inaccurate for measurement. But if the arm circumference exceeds these values, between 29 and 42, 43 or more, you can find overestimation of the blood pressure by using this smaller cuff bladder size. If you use this bladder large size, 15 by 33 centimeter, it will be very appropriate and accurate for the arm circumference between 29 and 42 centimeter. However, it will underestimate blood pressure if arm circumference is smaller, and overestimates blood pressure measurement if arm circumference is bigger. If you use this big one, it will be inaccurate for arm circumference exceeding 43 centimeter, but it will underestimate blood pressure if the arm circumference is less than these values. So selecting the proper cuff size is one of the important points toward measuring the blood pressure accurately. So this is an important point. Regarding home blood pressure monitoring, there are practical information that should be addressed. So the technique: use only one arm, only an arm cuffs, not wrist or finger. Appropriately size the cuff to match arm size, as I mentioned in the previous slide. At least 5 minutes of quiet rest before measurements. Obtain readings in duplicate twice daily, morning before medication and evening before dinner for 7 days. Use the average of 7 days to make clinical decisions. In patients with high blood pressure variability, there may be value of measuring blood pressure more frequently than advised here. So this is the technique. Regarding interpretation, we should know that home blood pressure less than 125 by 76, the advisors continue to monitor. Or if the patient is treated with antihypertension, to continue the same treatment. If home blood pressure exceeds 135 by 85, start treatment or escalate therapy if the patient is already on treatment. If home blood pressure between 125, 76 and 135, 85, obtain ambulatory blood pressure monitoring. If 24-hour ambulatory blood pressure monitoring average is less than 130/80, continue same strategy. If higher, start or increase treatment. So we should put all these in our mind. Another important point is the presence of motion artifacts, because motion artifacts can lead to inaccuracy in blood pressure monitoring. So motion artifacts are considered external sources of inaccuracy, and it can be due to sudden arm motion, muscle tremor, shivering, and transport vehicle vibrations. In the proposed work of this article, a new algorithmic stage is integrated in a non-invasive blood pressure monitor. This stage suppresses the effect of motion artifacts and adjusts the pressure estimated before displaying it to users. The proposed stage is based on 3-axis accelerometer signal, which helps in the accurate detection of the motion artifact. Both transient motion artifacts and artifact due to vibrations are suppressed using algorithms based on empirical mode decomposition, EMD. So this means that we need to know how to monitor, how to measure blood pressure and the different methods for accurate measurement. Let us to review the current guidelines of this year that is already accepted and is still we are waiting its publication for healthcare professionals who have been specifically trained to measure blood pressure accurately should assess blood pressure in all adult patients at all appropriate visits to determine cardiovascular risk and monitor antihypertensive treatment. Again, the grade is D. It is this is the grade of evidence. It is low grade, but it is recommended because this is the general advice for the general well-being of the patients. Use of standardized measurement technique and validated equipment for all methods. Automated office blood pressure, non-automated office blood pressure, home blood pressure monitoring, and ambulatory blood pressure monitoring. All these are recommended. And when we use any measurement technique, we should know the limitation and definition of hypertension based on the method of measurement. So if we use automated office blood pressure, the cutoff point for definition of hypertension is systolic equal or exceeds 135, diastolic equals or exceed 85. If we depends on the traditional method, non-automated office blood pressure, here 140 and 90 is the cutoff point for systolic and diastolic. Above them, or equal them, this is a stage of hypertension. If the systolic blood pressure, depending on non-automated office blood pressure, between 130 to 139 systolic, or 85 and 89 diastolic, it is high normal blood pressure. If we are depending on ambulatory blood pressure, according if we use awake values or the 24-hour values, if you are using awake values, if it is equal or exceeding 135 systolic, 85 diastolic, this is a hypertension. If we depend upon 24-hour ambulatory blood pressure, it is 130 and 80. If we use home blood pressure, if home blood pressure exceeding or equal 138, 135 and 85 systolic and diastolic respectively, this is hypertension. But if home blood pressure is less than 135, 85 and high office blood pressure, please repeat home blood pressure or ambulatory blood pressure. So this is the Canadian guidelines for adults. The use of home blood pressure monitor on a regular basis should be considered for patients with hypertension, particularly those with diabetes, chronic kidney disease, suspected non-adherence, demonstrated white coat effect, blood pressure controlled in the office but not at home, which is known as masked hypertension. Again and again, this is a very nice review, shows the association of nighttime home blood pressure with nighttime ambulatory blood pressure and target organ damage as a systematic review and meta-analysis. Within this meta-analysis, there is an accumulating evidence suggesting that nighttime home blood pressure monitoring is feasible and well accepted by the patients. Nighttime home blood pressure appears to have similar values as nighttime ambulatory blood pressure, and these monitoring methods are strongly correlated, have close agreement in detecting non-dippers, which is very important points, and give comparable association with indices of preclinical target organ damage. Due to its wide availability and low cost, this technique has the potential to be generalized in the primary care settings. However, there is need for further research to validate the optimal nighttime home blood pressure schedule, as well as outcome studies to confirm the value of nighttime home blood pressure versus ambulatory blood pressure in predicting cardiovascular events. So if we cannot do ambulatory blood pressure monitoring, looking at home blood pressure is very practical point, and myself I recommend this strategy. Another important question: is there a difference between isolated daytime or nighttime In the previous presentation, I stated that if I wanted to select between diurnal or nocturnal hypertension, I selected diurnal because nocturnal hypertension is more risky. In this study, the study addresses a question: is nighttime hypertension worse than daytime hypertension? A study on cardiac damage in general population. And this is an analysis that included 2,021 participants with valid ambulatory blood pressure monitoring. Subclinical organ damage was assessed by validated ECG and echocardiographic criteria. And the results, as shown in this figure, if we look at the percentage of individuals who had left ventricular hypertrophy, you can find there is no difference between isolated day and isolated nocturnal hypertension, but the risk is higher than the normotensive persons, and sustained hypertension persons had the highest risk of left ventricular hypertrophy. So again, both sustained nocturnal daytime hypertension are associated with risk of cardiovascular system. This is a very interesting point to look at the measurement of blood pressure, response of antihypertensive medication, and number of medications used by the patient. If blood pressure generally is less than 140/90, this is office blood pressure. This is controlled. If it is above 140/90, this is uncontrolled. So if it is controlled by 3 drugs, this is controlled hypertension. If it is controlled with the use of more than 3 drugs, this is controlled resistant hypertension. If the patient is uncontrolled with 2 drugs, this is uncontrolled hypertension. If the patient needs 3 or more, and principally one of them is diuretic, so this is the definition of resistant hypertension. And if the patient needs more than 5 drugs and the blood pressure is still above 140/90, this is a refractory hypertension. Again, this is just to enhance the exercise, because I know that the definitions, measurement of blood pressure are very crucial to start with. So let us to go to the different corners in this figure. If I start with this square, we have an individual who is not treated for hypertension. Office blood pressure is normal. Home or ambulatory blood pressure is normal. What's your diagnosis? The diagnosis is sustained normotensive individual. If we are dealing with the second corner, the person has high office blood pressure, normal home or ambulatory blood pressure. It seems that he has white coat effect, white coat hypertension. If we are in this third corner, high office, high home or ambulatory, this is sustained hypertension. If we are here in this corner, normal office, high home or ambulatory, this is masked hypertension. Masked hypertension means office is normal, but home or ambulatory is high. And this is another risky point for the left ventricular hypertrophy and other cardiovascular outcome problems. So this is regarding untreated persons. If the patient is already treated because of hypertension, and he is coming with normal office, normal home, and he is on drugs, so this is truly controlled blood pressure. If he is within this corner, high office, normal home or ambulatory, this is false resistant uncontrolled hypertension, white coat resistant uncontrolled hypertension. If the patient is here, normal office, high home or ambulatory blood pressure, this false blood pressure control, masked resistant uncontrolled hypertension. High office, high home or ambulatory, this means truly resistant uncontrolled hypertension. Again, we are using 135/85 for home and daytime ambulatory blood pressure monitoring, 130/80 for 24-hour ambulatory blood pressure monitoring to say normal, or 120/90 for nighttime ambulatory blood pressure to say this is normal or controlled blood pressure. Another important point regarding blood pressure trajectory, which is another point to be respected. This study included 762 participants of Ranco Bernardo study, and this is the different trajectories. Trajectories mean the direction of systolic blood pressure. So systolic blood pressure trajectories were derived using group-based trajectory modeling. This is the method. And Cox proportional hazards analysis was used to investigate association of trajectories and average systolic blood pressure with cardiovascular disease and all-cause mortality, adjusted for age, sex, cholesterol, smoking, diabetes, and antihypertensive medications. Mean baseline age was 65 years, and 67% were women. 4 trajectories were identified in which mean systolic pressure increased by 5 to 12 millimeter mercury during 10 years. The highest trajectories were associated with 2 to 3 times greater cardiovascular mortality and 1.5 times greater all-cause mortality risk compared with the lowest trajectory. Each 20 millimeter mercury increment in average systolic pressure was associated with 1.4 times greater cardiovascular mortality and 1.2 times all-cause mortality. So this is what is known about the topic, and what is this study is added. And in addition to what I said, systolic blood pressure trajectories were not superior to the average systolic blood pressure in predicting cardiovascular disease and all-cause mortality. This means we need to refine our tools to know blood pressure even more. You can have normal brachial pressure as measured in the office, but high central systolic pressure as known from the pulsed wave analysis. This study discussed an important issue, which is using the central systolic pressure. This study included 100 patients with well-controlled hypertension. They were analyzed for central systolic blood pressure estimation, and this was smart because they used the arteriograph tension med limited, which uses one cuff for all measurements, single point measurement approach, and the high proportion of treated hypertensive patients had central systolic blood pressure level that exceeded their brachial blood pressure. So central systolic blood pressure, so long as central systolic blood pressure positively correlated with lower height and shorter return time of the reflected pressure wave, and was significantly higher in female compared to male. So we should put all these variables in our mind. Again and again, we need to refine blood pressure measurement. I attended the 18th conference of Dumyat for cardiovascular and diabetes conference, and this was one of the presentations there, blood pressure variability, a masked enemy. So even if it is debated, I don't like variability in anything in medicine, because variability can be considered as unphysiological. And within this presentation, Professor Ragab mentioned short-term blood pressure variability within 24 hours, very short beat to beat, short within a 24-hour period, minute to minute, hour to hour, and day to night, and long-term blood pressure variability, day to day, visit to visit, seasonal. However, we should think of artifact variability. What are the causes of artifact variability? Patient position, patient relaxation, arm support, arm position, equipment used, calibrated or not, cuff size, appropriateness, release of the cuff, fast or not, multiple measurements, discussing and reporting. So all these should be put in mind before we discuss the variability. And this is one of the nice articles addressing a question: does blood pressure variability predict the outcome of acute ischemic stroke? And in conclusion of this article, blood pressure variability after the first 24 hours of acute ischemic stroke appears to represent a promising tool for the prediction of long-term outcome. However, larger studies are needed to confirm these findings. If this association is validated, interventional studies using antihypertensive agents with different effects on blood pressure variability are needed to clarify whether decreasing blood pressure variability will translate into better outcome. A very interesting point is this study, because the study included approximately 2,000 individuals aged 25 to 41 years, addressing the correlationship between healthy lifestyle and blood pressure variability in young adults. So the lifestyle score for 0 to 7 was calculated by giving 1 point for each of the following components: never smoking cigarettes, adhering to healthy diet components, never performing moderate or intense physical activity, having a body mass index less than 25 kilogram per square meter, a total cholesterol less than 200 milligram per deciliter, glycated hemoglobin less than 5.7%, or a conventional blood pressure is less than 120/80. Standardized ambulatory 24-hour measurements were obtained in all individuals. Blood pressure variability was defined as a standard deviation of all individual ambulatory blood pressure recordings. So this is a very interesting study, and they concluded that young and healthy adults adopting a healthy lifestyle was associated with what? With lower blood pressure variability. And these associations were independent of the mean blood pressure levels. So very interesting. If we go to the last year guidelines for the diagnosis and the management of hypertension in adults regarding the sector of suspected blood pressure variability, the recommendations are: for high-risk patients with suspected high variability in systolic blood pressure between visits, a focus on lifestyle advice and consistent adherence to the medication is recommended. So should think of these two important parameters. Drug therapy should not be selected based on reducing blood pressure variability per se, but in accordance with current recommendations, which already prioritize the most effective medications. Both of these recommendations are strong recommendations. And the most important point is we should refine our measurement of blood pressure to be unified all through the follow-up visits, and at the end selecting the best treatment for the patient. This will keep the blood pressure within a stable fashion and to avoid variability. As I mentioned, although you may find some debated issues regarding variability in different parameters in medicine, but I don't like variability in any physiological point. Here we are speaking about variability in blood pressure. Let us go to the second sector of the presentation, and in this workshop, treatment strategy, goals, and approach. And principally, I'll use the Canadian guidelines for adults. Here, we are stressing on the healthy lifestyles. We should encourage physical exercise for non-hypertensive individuals to reduce the possibility of becoming hypertensive, or for hypertensive patients to reduce their blood pressure. Prescribe the accumulation of 30 to 60 minutes of moderate intensity dynamic exercise like walking, juggling, cycling, or swimming 4 to 7 days per week, in addition to the routine activities of daily living. This is grade D. Higher intensities of exercise are not more effective. This is an important point. So just advise your patients for walking. For non-hypertensive or stage 1 hypertensive individual, the use of resistance or weight training exercise such as free weight lifting, fixed weight lifting, or hand grip exercise doesn't adversely influence blood pressure. Weight reduction, another important point to be tackled, to measure waist circumference for our patients, because visceral obesity is bad for cardiovascular, especially if it's coincident with hypertension. So maintenance of healthy body weight, body mass index less than 25 kilogram per square meter, and waist circumference less than 102 centimeter for men, or 88 for women. This according to the Western guidelines, and you can find differences according to the races. And for hypertensive patients to reduce blood pressure, all overweight hypertensive individual should be advised to lose weight. And this is a grade B evidence. Weight loss strategies should employ a multidisciplinary approach that includes dietary education, increased physical activity, and behavioral intervention. So exercise, weight reduction, and a DASH. What's meant by DASH? Diet approaches stop hypertension, less in calories, high in fibers, fruits and vegetables. Reducing sodium intake towards 2000 milligrams. This means 2 grams sodium. That equals 5 grams of sodium chloride per day. And this is grade A evidence to cut short salt. In patients not at risk of hyperkalemia, increasing dietary potassium to reduce blood pressure. Both of these recommendations carries grade A evidence. And this is from up to date, showing the modification in lifestyle and its repercussion on blood pressure. So weight reduction may lead to 5 to 20 millimeter mercury drop per 10 kilogram weight loss. Adopting DASH diet, 8 to 14 millimeter mercury loss, drop in blood pressure. Dietary sodium restriction to 8 millimeter mercury decrease. Physical activity 4 to 9 millimeter mercury decrease, reduction in systolic blood pressure. Moderate alcohol consumption here, this is the results of these. This is a very philosophical article, still it's just accepted, discussing the role of salt. Is salt a culprit or an innocent bystander in hypertension? A hypothesis challenging the ancient paradigm. And this review is very interesting, suggesting that consumption of high salt diet is not the cause of hypertension, and that there are other factors such as added sugar which are causative for inducing hypertension and cardiovascular disease, as you see in this figure. Promoting wide sodium restriction, reduction in sodium content of food but stable physiological drive to consume sodium, increases consumption of low sodium foods to meet unchanged physiological sodium demand, great intake of refined carbohydrates, trans fats, and other unhealthy components with greater intake of processed foods. At the end, increased incidence of hypertension, obesity, insulin resistance, type 2 diabetes, and cardiovascular disease. So again and again and again, we should look at the diet a multidisciplinary approach. Yes, salt restriction should be. We shouldn't advise high salt intake for hypertensive individual, even if the role of salt in causation of hypertension is minimal, as stated in this review. But we should stress on salt restriction to the level that I mentioned, 2 gram sodium, that equals 5 gram sodium chloride, and we should concentrate on the other component of the diet. We avoid processed foods, high calories, etc. It's a very interesting review that shows the important parameter, sodium excess and potassium deficit enhances central sympathetic nerve activity. This is a very interesting point because sodium excess and potassium deficiency act centrally on the brain, leading to increasing the central sympathetic nerve activity, raising peripheral vascular resistance, and generating hypertension. The central effect of sodium and potassium involves several signals arising from blood stream and CSF as non-circulating brain renin angiotensin aldosterone system, and the local production of endogenous wellbeing. Potassium administration, this is a very important point, is a powerful natural antidote for sodium excess. This is why in the guidelines they stated sodium restriction and giving potassium, and this is another, I want to repeat, this is a grade A evidence. If you are not afraid of hyperkalemia, reduce sodium and allows potassium to control blood pressure. Again, we are coming back to the Canadian guidelines. regarding the medical treatments of hypertension, when to treat. When to treat hypertension, antihypertensive therapy should be prescribed for average diastolic pressure of 100 or average systolic pressure of 160 or above. This is grade A evidence. In patients without macrovascular target organ damage or other cardiovascular risk factors. So we should evaluate the cardiovascular risk. If there is no cardiovascular risk factors rather than blood pressure and no evidence of macrovascular damage or target organ damage, we can start treatment if systolic blood pressure exceeds 160 or diastolic 100. Antihypertensive therapy should be strongly considered for average diastolic above or equal 90, systolic above or equal 140, grade B, in the presence of macrovascular target organ damage or other independent cardiovascular risk factors. So we treat the patient overall. So we should evaluate the risk first before deciding the treatment. This is a very interesting point. If there is cardiovascular risk factors, we treat earlier to the level 140 and 90, as I mentioned. Recommended monotherapy after adopting healthy lifestyles for all, exercise and diet, we can start with monotherapy. Thiazide-like diuretics, this is a grade A evidence, was longer acting diuretic preferred, like chlorothalidone or indapamide, as I'll mention in the diuretic sectors. Grade B. Alpha blockers in patients younger than 60 years. Beta blockers in patients younger than 60 years. Grade B. Angiotensin converting enzyme inhibitor in non-black patients. Grade B. Angiotensin receptor blocker. Grade B. Long-acting calcium channel blocker. Grade B. So these are the drugs of first line for management of hypertension, starting at monotherapy, as I mentioned. Recommending single pill combination choices are those in which an ACE inhibitor is combined with calcium channel blocker. This is a new guideline, level A. ARBs with calcium channel blocker, grade B. ACE inhibitor with diuretics or ARBs with diuretic, grade B. Hypokalemia should be avoided. As I mentioned, potassium is important for regulation of blood pressure, and it is a friend for treating hypertension. So hypokalemia should be avoided in patients treated with thiazide-like diuretic monotherapy, grade C. A very interesting paragraph in the guidelines. Alpha blockers are not recommended as first-line agent for uncomplicated hypertension, grade A. Beta blocker are not recommended as first-line therapy for uncomplicated hypertension in patients 60 years or older, grade A. ACE inhibitors are not recommended as first-line therapy for uncomplicated hypertension in black patients, grade A. However, these agents may be used in patients with certain comorbid condition or in combination therapy. All these are very important points to put in our mind when we decided to use the antihypertensive treatment. This is a women's health across the nation prospective cohort study, included 3,000 women, discussing the effect of race and ethnicity on antihypertensive medication utilization among women in the United States. So this is the main results. Among this larger cohort of multicentric midwife women, use of antihypertensive medications increased over time, with angiotensin converting enzyme inhibitors or ARBs becoming the most commonly used antihypertensive medication, even for blacks. Thiazide diuretic utilization is increasing over time for all race, as did use for calcium channel blocker among blacks. So here the use of calcium channel and diuretics in blacks is increasing. Both patterns are in line with guideline recommendations. So this is just to show this. A very interesting point, chronotherapy, following the blood pressure all through the 24 hours, day and night. So put in mind, a pill in the night makes everything right. So a pill at bedtime and your heart is fine, bedtime hypertension chronotherapy, and opportune and advantageous inexpensive treatment strategies. So just distribution of the blood pressure management through the day, which is known as chronotherapy. And here I want just to advise, if we use more than one drug, so it's better to put one in night, so at bedtime. But be careful. I think diuretics are not preferred to be taken before night, before bedtime. So use any drug except diuretics at bedtime. This may add a lot for the management of hypertension. If we go together to the compelling indications, if you have heart failure, the best drugs, diuretics, beta blocker, ACE inhibitors, ARBs, aldosterone antagonist. Post-myocardial infarction, beta blockers, ACE inhibitors, aldosterone antagonist. High coronary disease risk, diuretics, beta blocker, ACE inhibitors, calcium channel blockers. Diabetes, diuretics, blood pressure, ACE inhibitor, ARBs, calcium channel blockers. CKD, ACE inhibitor or ARBs. Recurrent CVA, diuretics, calcium channel blockers. So according to the patient situation, we may select the proper drug. According to the up-to-date systolic heart failure, ACE inhibitor, beta blocker, diuretic, aldosterone antagonist, and even using sacubitril neprilysin inhibitors, which is currently stated in the guidelines. Post-myocardial infarction, ACE inhibitor, beta blocker, aldosterone antagonist. Proteinuric chronic kidney disease, ACE inhibitor or ARBs. Angina pectoris, beta blocker, calcium channel blocker. Atrial fibrillation, beta blocker, non-dihydropyridine calcium channel blockers. Atrial flutters, beta blocker, non-dihydropyridine calcium channel blockers. Likely to have favorable effect on symptoms in comorbid condition. Benign prostatic hyperplasia, alpha blocker may help. Essential tremors, beta blocker may help. Hyperthyroidism, beta blocker may help. Migraine, beta blocker may help. Osteoporosis, diuretics because of anti-hypercalciuric effect, hypocalciuric effect of thiazides, helps in management of osteoporosis. To overcome Raynaud's phenomena using vasodilator like dihydropyridine calcium channel blocker may help. These drugs are contraindicated in these situations. ACE inhibitors in the presence of angioedema, beta blockers in bronchospastic disease, reverberating depression, methyl-dopa in liver disease, ACE or ARBs or renal inhibitors in case of pregnancy, beta blocker, non-dihydropyridine calcium channel blockers in the presence of second or third degree heart block. Beta blocker has side effects in the presence of depression. Diuretics may increase the risk of gout. Aldosterone antagonist, ACE inhibitor, ARBs, renal inhibitor increase the risk of hyperkalemia. Thiazide diuretics, hyponatremia. ACE inhibitor, ARB, or renal inhibitor in the case of renal vascular disease to be caution or increasing adverse effects. So we should look at the patient as a whole and selecting the best for the best in the same moment, because this is a personalized medicine. Selecting the best treatment for certain individual in a certain time point according to risk factors. Regarding the combination, there is a philosophy of combination, and this is the color-coded. The green line means recommended and preferred combination. So calcium antagonist plus angiotensin receptor blocker, calcium antagonist plus ACE inhibitor, calcium antagonist plus diuretics. All these are green line. Diuretic plus ACE inhibitors is green line. So all these are preferred. The red line is a warning sign. So please don't combine ACE inhibitors and angiotensin receptor blocker together because of the risk of renal failure and other side effects. So, and if you follow the other lines, this is dotted green, useful, dotted black, possible but less well tested, and the red not recommended. As I mentioned, the green is preferred. Again, I'll start to look at certain individuals who have high systolic blood pressure equals or exceeding 180 and diastolic 110 millimeter mercury without symptoms. How to manage? So this is severe asymptomatic hypertension. This table shows the medical how to tackle medical history in evaluation of severe asymptomatic hypertension. So look at previous hypertension, duration and levels, personal history, discussing all these points, coronary heart disease, congestive heart failure, etc. Risk factors: family history of hypertension, hyperlipidemia, diabetes, tobacco, smoking, others. Secondary causes: family history of kidney disease, personal history of renal disease, medications and illicit use of different drugs, metabolic disorders like thyroid disorder, pheochromocytoma, hyperaldosteronism, target organ injury damage, neurological headache, vision change, seizures, neurological deficits can be clue for neurological. This is a very important clinical point. Chest pain, shows no breeze, myocardial infarction, syncope, history of palpitation or arrhythmias for cardiovascular, oliguria, even anuria for renal, acute shutdown, claudications, cold extremities, weak distal pulses for peripheral arterial diseases, sleep apnea, chronic lung disease for pulmonary disorders, concurrent medications, and I'll give a slide for the concurrent medication later on, compliance and antihypertensive. So we should ask about all these points. We should follow the proper blood pressure recording as I discussed. An appropriate size cuff, initially measured, should be obtained in both arms, and the higher blood pressure should be used. Significant differences between arms occurred in aortic coarctation, subclavian artery stenosis. The patient should have an empty bladder and remain seated with leg uncrossed for 5 minutes before the measurement. The measurement should occur at the level of the heart with the arm resting on a table. Postural blood pressure should be obtained in older adult. A minimum of 2 readings should be obtained 1 to 2 minutes apart and averaged. The diagnosis of hypertension should be confirmed at a subsequent visit unless the blood pressure reading is very high or the patient is symptomatic. Evaluation of white coat effect, as I mentioned before. The recommendations, and this is a clinical recommendation: patients with severe elevated hypertension should have a history and a physical examination to distinguish between severe asymptomatic and hypertensive emergencies with evidence of end organ damage. This is the evidence C. A 30-minute rest period is recommended when the initial blood pressure reading is severely elevated. In more than 30% of patients, the blood pressure will lower to an acceptable level without intervention following the rest period. An immediate diagnostic evaluation is not required in the initial management of severe asymptomatic hypertension, although the majority of them may be confronted in the emergency department. Aggressive lowering blood pressure, this is the most important point that I want to address. We should avoid drastic reduction of blood pressure, rapid reduction of blood pressure, because of the bad consequences. Aggressive lowering of blood pressure can be harmful and should be avoided in patients with severe asymptomatic hypertension. Gradual reduction over several days to weeks is recommended. Blood pressure control is best achieved with initiation or adjustment of antihypertensive. Current recommendations are to gradually reduce blood pressure over several days to weeks. However, if you opted to use correction